Okay, we are live. Excellent. All right, we'll start the session. Hello, everyone. Can you hear me?
Yes.
Oh, hello. Okay. Hi, Dr. Ramsha. How are you?
Hello, I'm good. How are you, Dr. Rizwan?
I'm good. I'm good. Thank you for taking the time and joining us, running this live sessions for all the participants. Participants, can you hear me?
Yes, I'm here. You.
All
We
right.
can hear.
Excellent. 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 How's everyone doing?
Great.
Yes, I'm good.
Okay, good, good. What's happening in life? Study,
Many
study, and more
things.
study? Okay, tell me
Yes.
something.
Yeah, I study every day, and I decided to stopping my work before I'm going to have an exam
Okay.
because this concerns me a lot because I have
Mm.
to do an online exam, which is very strange for me.
Yep. And when is your exam date, Dr. Domitong?
On 17th of May.
Okay. All
So
right. So it's
before our class end, I mean the class that I have bought,
mm-hmm.
which is an AMC online class, it
Yep.
will
Yep.
be end on June, but my exam is on 17th of May.
I see. I see. So obviously this is well, first of all, congratulations because you managed to find the exam date. Not many people have been able to do that. So that's good. And I think you've got reasonable amount of time. If your exam is in May and we are in March, April, and May, you've got about 6 to 7 weeks, right?
Yes, but
Yes.
because I have to go to Melbourne for
Yep.
my son's preparation for his Swinburne University.
Yep.
So I will lose a class for about 10 or 11 days during that time
Oh,
because
really?
years is year is very sad that I have to absent from the class at that time. But
Hmm.
I try my best. If I have time, I would attend the class at that time too.
Perfect. Look, I mean, I think that's the spirit. You got to give it your best shot and leave the rest. All right. So, welcome, participants. I think, in the interest of the time, we'll start. We've got about 17 participants, quite a number of cases to go through. What me and Dr. Ramsha have done is actually started off with some new of the cases which have been circulating around, and I've tried to make sense of it all. But I think with the recalls, there's always a margin of error that what the participant actually recalls would not be exactly the case which has come in the exam. So I've tried to rationalize it by giving it more factual basis to it. And remember, this exam has to be done on your confidence and not on your recall knowledge only. Okay, so what we'll do today in a session. Before I start, my name is Dr. Rizwan Qureshi, and you know me through Emergency Focus. I work as a consultant in emergency medicine um, in Wollongong Hospital and Liverpool Hospital, and obviously run all these courses for IMGs, in particular AMC1 clinical orientation courses, and also in-person courses. So we going good. Thank God for that for the last couple of years and getting quite a bit of traction. Now, in terms of the session today, we're going to talk about planning your AMC clinical, how to go about in terms of timeframes, the books. I always like to share some of the early slides in terms of your planning. We're going to talk about some of the history taking tips and the communication tips, and then we'll dive right into the cases. So I'll have a few cases, and Dr. Ramsha, I believe, has got some cases as well. So just to give you a flavor of what's coming on and what to expect and how to actually better equip yourself when you're dealing with the cases or the variation of the cases. And finally, I'd like to talk about top 5 things to avoid in this exam. We'll open the pot for the questions. So in terms of planning, look, everybody's got their own style of exam, and I'm not saying that you should follow the style which I'm recommending, but I think you'd probably agree when I say that you need to aim for passing all 16 stations. Don't aim for the bare minimum. And even this is valid for the some of the participants who are actually sitting the recalls. Sorry, not recalls, retests, or doing the exam for second or third time. Aim to pass all 16 sessions. Like majority of the participants who do this exam are able to pass at least 7 or 8 stations, sometimes even 10 stations. So you're not far off if you look at it. And this exam, I always maintain, is one of the easiest exam to pass if you know how to approach the station, which we'll talk about, and how to, you know, exactly take every historical aspect and then the communication aspect on its merit rather than being very formulaic, which will tend to miss out things. And when we're following a formula, we tend to think that we're doing something right, but this exam is also about keeping yourself available and robust and open to variation. um, you need to have a simple, repeatable routine. If you're studying 4 hours a day, that is brilliant. That is something that you need to be doing for ongoing for at least 10 to 12 weeks. So that's about 3 months of study time. And if you can do that and keep on doing that for 10 to 12 months, sorry, not 10 to 12 weeks, you should be fine. Now, one thing I always maintain that this exam is all about practice, and proactiveness is very important. So just make sure that you are practicing real exam cases from day one. Okay. And there's not much point being passive, watching videos, and just staying in the background. Sometimes we do courses, and I'm not sure even today, then when I try to get participants to do the cases with me, everybody tends to walk away, and some of them are shy, and some of them just don't want to participate. And I think you should grab the opportunity of participating in as many cases as possible. And it doesn't matter if it's a free session or if it's a course session or if there's any session. Uh, and don't spend too long hours. It tends to dilute your concentration. um, that's what we're trying to do with our courses as well. We don't try to keep our session any more than 3 hours. If somebody's trying to fool you into doing hours, 5 hours or 6 hours sessions, that's just ridiculous. I don't think that you can retain any information doing 6 hours of study. I don't think it's possible. You may think that you're doing very well getting on top of the subject, but honestly, you're not doing yourself any service. um, Now, in terms of the books, I like AMC Handbook of Clinical Assessment. It has got all the cases, it has got all the requirements, and everybody knows that. For reference, no prize in guessing. Merta seems to be the best source out there. But I wouldn't say that you need to memorize any of the information. I think the emphasis and the concentration here is on practice, and practice as much as you can, because that's how the communication will unfold. That's how you will actually gain more confidence as you keep on performing cases. And if I was to put an hour time into this whole scenario, that how many hours will it take to practice all these stations, I would say probably about 100 hours. If you practice or spend 100 hours of your life for AMC Clinical doing number of sessions, you should be good as gold. All right, any questions at this stage?
About the handbook of clinical assessment, is there any new version or new edition of this, or is
Look,
this just a the
yeah,
first
so
edition?
yeah, so this is the handbook that I've got here in my shelf as well. I have got a version of it which is I'm not sure which edition is that. Can you see that? This one.
Yeah, it
Yeah.
seems to be this the first edition or just
Yeah.
only
Look, I'm
single
not sure.
edition.
It's worth checking on the website if there's a new edition of this book which has come out. But look, this edition, there's hardly any variation in these books. There might be some subtleties, but we tend to cover most aspects in our course. So as long as you've got one book which you can go through and keep as your, go-to reading resource, that should be fine. Any version should do, and the rest you can build up with attending these sessions. Dr. Ramcha, do I need to add anything else? Dr. Ramcha is there.
Yes. No, I think you covered most of the points, and I think there's no new edition of the handbook.
Okay.
So it's the same.
Well, there you go, Dr. Tomicon. No new additions. So I think you
Yes,
can
thank
use
you.
one.
No worries.
Okay.
Excellent, excellent. All right. Okay. Has anybody got any questions for me? No, at this stage, we'll move on. I think this. Okay. So those of us who are doing the cases or the courses with us actually would know about the slides, about reading the tasks, reading the questions, diagnosis, differentials, and planning the task. That's what I typically say outside the stations. Thanks to the COVID being ending now, we have got an approach in which you have 2 minutes outside the station and obviously 8 minutes inside the station. Now, 2 minutes need to be spent very methodically. You read the tasks first, and these are the tasks like take the history, work up your diagnostic formulation in terms of main diagnosis and differential diagnosis, and if there's anything else attached to it like management, counseling, and so forth. And these 2 minutes need to be, and I feel at certain point that these 2 minutes are a deal breaker for most people, because if you're able to understand how you need to spend these 8 minutes will go very well, right? But if you don't really plan in these 2 minutes, then these 8 minutes will be a devastation. Once you're inside, then obviously a very simplified approach in terms of introduction, comfort, consent, and stability of the patient is also important. Now, most of the times you would be given vitals on the screen or in person when you're doing an in-person exam, which will be more of the exam available from June onwards, which is good. Rapport. Rapport, we'll talk about what does rapport mean. I think there seems to be a lot of confusion around what IMGs understand by rapport. And there seems to be some formulaic, responses. Yes, I sympathize with you. Yes, I understand. And they might not float well. So we'll talk about what is a better wording for rapport. Okay, so this is where I want you to hook on to your hook on your concentration when we're going through that. Now, frameworking is an absolute marvelous thing. Frameworking is something which I'm a big fan of, which is breaking down your 8 minutes into a segments of 2 minutes each and giving headings that look, this is the plan. I'm going to go through history. I'm going to examine you. We'll talk about what would be the possible diagnosis and differentials. And finally, we'll talk about the management. Is that okay with you? So a framework not only gives you a mental memory of what you need to do in your 8 minutes, but also tells your examiner that these are the tasks which you're going to cover. Okay. Finally, diagnosis and differentials. We'll talk about that. I've made a little schema in terms of what diagnosis and what differentials are really important, because there could be a number of different differential diagnoses, and you don't have to mention each and every one of them. You need to have a fair bit of an idea that this is more relevant differentials, and this is the diagnosis which we must base our case at. Management will also break down the management. What does management actually means and how should it be carried out in AMC scenarios? And finally, a summary is a brilliant way of ending your station. In fact, I would say that even if you've done something wrong and you're not ticking all of the boxes, summary is that last 30-second summary, is that savior which can get you from almost, uh, if you're not quite there yet, to pushing you across the line. So summary, please always remember, and this is your opportunity to say that, is there anything else? I'll give you some information. These are the danger signs that you need to come back to the hospital or GP practice. And is there anything else that you'd like me to touch back? And they might be able to float this questions that, look, doctor, you did not really explain to me about the asthma management. You don't not need to give me the like management plan about how to manage my HRT and so forth. Um, as you know, most of the cases that we get in clinical exam, almost 70% of this is going to be history taking and diagnostic formulation. All right. And the rest of the cases will be, physical examination. There will be some pure communication skills, but the communication in general is built into all of it. So it's not tested separately. Some of the scenarios, yes, breaking bad news and conflict resolution might be there, but then again, communication is an essential part of all the scenarios. Does it sound reasonable, Dr. Ramsha, or is there something else that you'd like to add on?
Yeah, it sounds reasonable.
Okay. Now, one thing about the AMC exam scenario, as I was saying, that what does it mean by diagnostic formulation? And I'd like to think it very simple, because I am a very, very simple man. And please ignore me if I'm way too simple. sorry, way too simple. I'd like to think about what is the most likely diagnosis. Okay, so if the patients come in shortness of breath and wheeze, the most likely diagnosis in a 70-year-old smoker would be a COPD. What would be the second likely diagnosis? Well, the second likely diagnosis could be any variation of CPD, which could be an infection, which could be a lung cancer, which could be anything, okay, which could be a complication arising from that pre-existing condition. And the most serious that I need to exclude, like that serious diagnosis, which could be a life-threatening, could be a clot, it could be acute myocardial infarction, it could be aortic dissection, which could be closely related to the primary diagnosis. And we'll do the cases and go through that to make it more significant. But this is like a key gold information. If you train yourself working through this, that these are the three things that I need to check: most likely, second likely, and most serious, you're not going to fail the scenario in terms of diagnostic formulation. um, Obviously, more the differential diagnosis, the better your argument and case. But then again, sometimes we tend to dilute the overall work that we've done in the last 8 minutes by giving completely non-relevant differential diagnosis. So I don't want you to do that, because it bores the examiner and puts you into a danger zone. Now, um, okay, all right. And remember your tasks. I think the task people tend to sometimes forget, because sometimes there could be many tasks. And that's why I always encourage, in fact, it's one of the tutors here, Dr. Sandia, who always, who told me that, look, we need to get our participants to actually start off reading the task, because sometimes the scenarios can be very long and it can waste a lot of time. So please read the tasks first, and then you can screen the scenario and get the relevant information that you need to give in the next 8 minutes. Now, um, I'll now be talking about the history in terms of what would be the crucial step of taking the history. Has anybody got any questions at this stage? Dr. Ramsha, have you got anything to add in terms of AMC exam plan or anything like that?
It's just that the communication is very important. How
Mhm.
you're communicating with the patient and you're making the patient feel comfortable, that's the most important point. I think that what helped me pass the examination was I was able to make a very patient-centered plan, and always ask your patient if the patient is happy with the plan and if the patient is ready to follow the management and everything. So that is very, very important.
And you can see, Dr. Ramsha, how clearly she speaks. And I think that clarity and very, um, almost like a very, I think there's no trouble I'm getting in terms of understanding her. And her pacing of words is perfect. So that what she was talking about, patient-centered approach, is that patient is able to understand that communication in terms of what she's saying is actually received. If I'm a patient, I'm able to understand Dr. Rapsha because she's clear and she's specific to the patient's issues. Is that what you're trying to say, Dr. Ramsha?
Yes, and you have to show sympathy. I mean, we have all heard it. Everyone's talking about how we should show empathy and sympathy to the patient, but that is one of the main points in passing the exam, that you have to be empathetic to the patient. You
That's right.
can't just go blabbing on and on and on. You have to stop, pause, and actually wait for the patient to tell you all about himself or herself. Because when you ask the patient, we always start the history with an open question. And
Hmm.
believe me, if you ask the patient, like, what's wrong with you? Why are you here today? He will just take 30 and 40 seconds and he'll tell you everything.
Hmm.
So you'll get a very good idea of the case from there onwards.
Okay. Now, there's a question, Dr. Ramsha. I think you might be in a better position to answer this. Will there be a procedural station such as orthopedic procedure and blood cultures technique? This is a
No,
new one for me. I
I
don't
don't think
know much.
so. I have
Yeah.
never seen any recall like that.
Yeah, and but I think this is something which may be piloted, even if it's not something which is come as far as yet, because I know sometimes in PLAB scenarios there could be some mention of that, and it's always good to have some sort of approach in your mind because you could be blindfolded. So have an approach in your mind, make few points, even if it comes as a pilot station. The AMC might be trying to gauge that. Look, is it worth putting these kind of things which are more practically oriented? All right. Okay. So in terms of history, look, I've broken it down into a few steps. And please bear with me in this one. So whenever, as I said, that majority of the sessions are based on history. So when you're initiating your session in terms of history, so there's a patient who's coming with shortness of breath or chest pain or abdominal pain or whatever it might be. Obviously, introduction is very important, and that's your introduction, your role, and what you're there for. That my name is Dr. Rizwan Qureshi. I'm here to ask you a few questions about your symptoms of shortness of breath, um, and at that point, I think you are developing a rapport. At the same time, you're gaining the confidence and trust of the patient. So that first line should be very punchy, because uh, that's what's going to tell the patient, which is an actor, and the examiner, that you've got this under control. The other thing is confirmation. And if you've got a confirmation, like you need to confirm the identity of the patient, is that, sometimes there could be a mistake. Let's just get everything right. You are Mr. So and so, and this is what you're here for. It's a good practice. Not that it might be relevant for the MC scenario, because the sessions that you've read might be the session that you're actually doing inside, but it's a good practice, which is more reflective of the practical work that we do. And I'll give you an example. It might be actually very funny. Sometimes, when I'm working in emergency department, I go and see the patient who's waiting in the waiting room, and I'll go and see them. And by the time I'll go and call out their name, I might be calling a completely different name. And it's a very common occurrence. So I think by confirming and correcting your thing, it might be more reflective of a practical approach that patient, like examiners say. So if you're comfortable with that, then look, I just like to confirm your identity. This is your name, and okay, and this is what you're here for. It's a good practice. Now, rapport building. Now, can I just get a show of hands in terms of what is an understanding from rapport? Like, what do you understand from rapport? Anyone? There are quite a few participants, in fact, 26 at this stage. Can anybody say anything about the rapport? Like, what is their understanding from rapport? Would like to keep it.
Rapport is like a connection, connecting
Yep.
with the patient.
Very good. Yes, that's excellent point. And how can you do that?
First, acknowledging the presence of the patient.
Yep.
When you confirm their date, like their names, and you have already introduced yourself, and welcome them just to tell you about themselves. That's the first thing to do.
So exactly right. So rapport is making them comfortable. You're absolutely right. Making them feel welcome. That not in a sense of welcoming them from the party point of view, but making them feel welcome. That look, you have come here for a problem, and we will solve this problem to the best of our ability. Also, rapport is that personal connection, which is not a part of your clinical history or clinical, like clinical diagnostic formulation. It's not clinical. It's more like based on empathy. So one of the things that you can do to develop a rapport, what can you do? So what would be the first thing that you can try to develop a rapport with a patient? Say, for instance, if I'm a gentleman who's come in with a chest pain. So what can you do? So you've introduced yourself, you confirm my identity, and made sure I'm the correct patient with the correct symptoms. How can you establish a rapport with me?
Yeah, can I try?
Yeah, go for it, please.
Yeah, so I think first, at the very first instance, I think
Sorry,
introducing
I didn't
ourselves.
didn't get your name. Sorry.
Ramesh, yeah.
Ramesh, please go ahead. Thanks.
Yeah, so I think at the first instance, introducing ourselves and asking the patient's permission to continue the history taking, as well as making sure the patient's comfortable in the beginning, asking them, are they in any pain? Is there anything that they can do prior to starting the history taking? Will kickstart the rapport building. I think it should be throughout the history taking, right? The rapport building.
Absolutely. You are 100% right. So rapport is something which is not just at the introduction and just at the end. It's not just saying, sorry, I feel sorry for you about symptoms. I'm sorry that you're experiencing all that pain, but it is embedded all throughout your introduction, your process of the history taken at the end. But what I'm trying to get at, and I think because we've got certain limited amount of time when you're doing the station, what you need to do in the rapport is acknowledge their symptoms. So mental note to yourself that if the patients come with shortness of breath, acknowledge that. Look, I can see that you're visibly short of breath. I can understand that you've got some pain. Would you like me to get you some painkillers? All right. Would you like to give me some? Would you like to give? Would you like me to give you some oxygen? All right. If the patient is distressed, Like if they are, there's a conflict resolution, breaking bad news, or some, some other adverse events which has happened, is there someone with you you'd like to be here before we talk about this any further? This is all a part of giving the patient or recognizing the patient as a person. um, I'll give you an example actually, and I'll try to give lots of example from our practical work. Yesterday, I had a patient at work who unfortunately unexpectedly died. In fact, she was brought into a peri-arrest and went into a full cardiac arrest and was unrevivable. We were thinking that she must have had a catastrophic brain bleed. When her daughter arrived and was put in the relatives' room, I had the social worker with me. Okay. And I was just observing the social worker connecting with the patient even before, me saying anything. That is there someone who'd like you to call? Is there something you'd like to be here before we start this conversation? And just so many allowances, like tissue paper boxes there, comfort is there, environment is set out right, and checking for support, checking for if you can make a call, checking that she's comfortable. So this is from the point of view, obviously, Breaking Bad's new scenario, that is there someone there you'd like to be here before we talk about this situation? Are you okay to talk about this situation? And things like that. Does it make sense, Dr. Ramesh? I think Dr. Ramesh is
So,
gone.
sorry, I muted my call. Sorry. Yeah, I
Okay.
understand. Thank you.
All right. So yes, it's just acknowledging patient as a person. Now, is screening for symptoms. Now, before I move into this part, I'll just invite Dr. Ramshad. Would you like to add anything onto that repo side of things?
No, I think you covered everything. It's just that we have to connect with the patient throughout our history taking session, especially when we are introducing ourselves and when we are asking the patient why he or she is here for, what he or she is here for. Yeah.
Fair enough. Yep, perfect. Now, is screening for symptoms. Now, anyone, Dr. Ramesh, anybody who'd like to have a chat, like tell me, what do you understand about screening from symptoms?
From what I understand, I think it will depend on the scenario that's given.
That's
For
right.
example, if the scenario is patient is complaining of chest pain, I think at the beginning itself, I should ask whether they are comfortable enough to continue with the history taking, and is there anything we can offer to reduce their pain prior to that further history.
So screening for symptoms is just like if the severity of the pain. You're right. I mean, we've already confirmed and we've already sort of introduced ourselves and developed that rapport. The next step would be to provide them with comfort. I always say that, look, a comfortable patient is far better patient when it comes to history giving in the real life. And I think you need to reflect that that is a natural course of action for you if you were to see this patient in emergency or in a GP practice. So absolutely right. Abdominal pain, how bad is it? Shortness of breath, how bad is it? Can I offer you something in terms of offering analgesia? And that's why it's there. Now, step 3, I'd say start off with open-ended questions whenever you're gathering information, because that's where your diagnosis is hidden. And instead of thinking that I need to diagnose this case in less than 2 minutes, uh, you know, be more liberal with your questions. Tell me why you're here. So open-ended questions. I understand that you're here from some shortness, but can you tell me a bit more about it? Um, Rather than just jumping right into the relevant negative and relevant positive findings. Shortness of breath, one, is it in particular time of the day? Is it associated with any cough? Is it associated with fever? Those very leading questions can be detrimental and may not give you what you want in terms of so give them chance to speak, because the diagnosis is known to your actor and they're the correct people who will give you the right information for you to make. She may say that, oh, I've had chest pain and shortness of breath for the last 48 hours. I'm quite all right, but I have come from a flight, or I'm quite all right, but I suffer from high blood pressure. I've had some angina. So they let them tell as much about themselves as they can, as opposed to you digging out. All right. So open-ended questions, important. Listening, and you can have, look, I mean, if there's a pain in particular, you can follow your schemas of Socrates approach or shortness of breath kind of questions, and all of that kind of things. but give the patient an opportunity to say as much as possible, at least for a minute. Yes, I'm hearing, I'm listening. And this is where your empathy and rapport would be even more. Oh, really? Tell me more about it. Fine. You said something about the shortness of breath. Okay. And then you can dig more and you can layer it up. Remember, one thing which I had said before at the start of the session, when you read the scenario, you already have a diagnosis in your mind. Okay, the scenario is 50% of the diagnosis. In fact, I would say 70% of the diagnosis is already there. What you're trying to do with your question is make a very, focused or pinpoint diagnosis and differentials. So utilize your presumption diagnosis which you've established during the reading of the scenario, and confirm that diagnosis when you're going through the open-ended questions, and then your relevant negative and relevant positive we should talk about. Now, step 4 should be summarization. Whatever the patient has given you, just go through that quickly. So I understand that you've come with some chest pain and shortness of breath. I understand that you've come with some abdominal pain. So is it correct in assuming you've had some nausea and vomiting with that? And this is a history that you've had previous bowel obstruction. So just picking up the relevant positive so that you're not missing out on anything. And that just keeps the loop of communication going. And at the end, obviously there's no point for guessing that. Ask if anything missing. There's absolutely no rules in saying that you cannot ask the patient if I'm missing out on anything or you'd like to give me some additional information. And you should utilize this opportunity at the end of the history taking. Now, in terms of the history taking finding, there are recurrent themes of questions, and you can ask the patient about the cardiac risk factors. You know about the cardiac risk factor. What are the cardiac risk factors? Dr. Ramesh, can you tell me cardiac risk factors?
So starting from modifiable and non-modifiable. So the modifiable risk factors can be unhealthy lifestyle, obesity, smoking, and the non-modifiable will be genetics, that means family history of hypertension, ischemic heart disease, and gender, postmenopausal state.
Yeah, so
That's all I can
obviously
think
there's
of right now.
that's obviously quite theoretically sounded, but any previous history of ischemic heart disease, any history of hypertension, smoking, any recent symptoms of worsening of cardiac condition, that could also, and smoking and family history, that is also one of the things. Thromboembolic issues, genetic or acquired risk factors for venous thromboembolic issue like DVT and PE, and in malignancy, obesity is relative risk factors for venous thromboembolic disease, and so forth. Cancer's questions in terms of fever, weight loss, tiredness, loss of appetite, which I've put it here. Now, at the end, how many people actually do systems review, or what does anybody practice systems review at the end of their history taking? Anyone?
Yes, I do.
Yeah, go for it, Dr. Jean. Would you like to say something? Dr. Pierre?
Yes.
Would you like to say something? I
Uh,
didn't.
yeah, you have to screen just system review, depending on what system the main complaint was about. You can screen, for example, in this case, it's more of cardiorespiratory, but you can screen for GIT problems.
Absolutely,
Maybe
yeah.
asking for any melena and abdominal pain the last time they opened their bowels,
Yeah.
stuff like that.
So some of
Or
the
urinary tract symptoms.
Absolutely. So the most common symptoms which you get in regards to any symptoms with the CVS, shortness of breath, palpitation, angle, swingle, I tend to take a top to toe approach. So if the respiratory symptoms, any, symptoms of lightheadedness, which might be a sign of hypoxia, confusion, or shortness of breath and cough, and any, blueness or cyanosis, things like that. So this just a quick screening questions which may point out towards a particular diagnosis of infection, malignancy, or any other thing. And constitutional symptoms like fever, weight loss, tiredness, loss of appetite towards a cancer, or low set infections. Finally, no history is complete about talking about if the patient has got any preset ideas or expectation that this is, and you can as I said, that always ask patients what are they worried about, And they may say that, look, I'm worried about a heart attack. I'm worried about my dad had a history of lung cancer. I'm worried about a cancer because I'm in that same age group when he was diagnosed as having a cancer. I tend to ask these questions. In practical life, it cuts a lot of time from my workup because I might be able to address these concerns without doing any tests. But sometimes, obviously, you need to do these tests. And background checks are very important in terms of past medical history, drug history, family and social history, in terms of calculating any risks which are pointing out towards any diagnosis. These are just sort of um, questions. So in summary, I'll just go back and cover that. So initiate the session with good, solid introduction, confirm the patient's identity, make sure that you are matching them with the correct symptomatology. Rapport is even though built in throughout the history taking session, but rapport might be just because of making sure that they're comfortable, making sure they're got that confidence. You mention them with an empathy that, look, I can understand that you're in a visible amount of discomfort. Let me offer you some painkillers, offering analgesia. Open-ended question in terms of pain, in terms of shortness of breath, in terms of any concerns that they've got about the situation at hand. And then close questions could be more directed towards a particular issue of pain with the Socrates approach, shortness of breath with any of your particular approach. Summary is important because then you will not miss anything. And finally, throw in a specific risk factor. If you think that the history is more leaning towards a cardiac, then cardiac risk factors. It is more leaning towards a cancer than cancer issues and venous thromboembolic issue. And finally, symptoms review. If there's anything which you have not really covered, like dizziness or palpitations or leg swelling or ankle swellings, then just quickly go through them because examiners may have them in their tick box. So that's the history. Dr. Ramsha, would you like to add anything onto that?
Yeah, I think you've covered most of the points. And it's just that past family history and any personal history and asking the patient's concerns are very important.
Yeah.
Because sometimes, as you said, the patient might be concerned about a breast cancer history running in the family or a cardiac arrest history running in the family. So we have to address that in the history as well as in the management as well.
That's right. So look, patient actually tells a patient actually tell you what is wrong and what I'm concerned about. You are just a facilitator of or a source of information between the examiner and the patient. Now, moving further, I won't say reasons to fail. I'll just say mistakes. Having a very formulaic approach. When we're doing these sessions, people come from all sorts of different courses, and they tend to have a very formulaic approach. And even though at times it's right, but having too much of a formulaic approach may just sounds very monotonous. And you'd be surprised that when you're doing these sessions with candidates and doing the trial exam, everybody says the same thing over and over and over again, and it can be very boring, and it may not really give you an edge as a person when you have got this very safe, very formulaic approach. Don't get me wrong, formulaic approaches are good for some leading questions at the end, but having a personality into your history taking is very important. I know English is not our first language, and some of us are not very capable of speaking very fluently, but then again, try create a difference in your history taking techniques, and that comes with the practice, which is non-formulaic or has at least got some variation, even though you might be following a formula. um, you might be surprised and that you may have read the task, that the task is to history take, the task is to examine the patient, and then um, you know you've only got 30 seconds left and you realize, yeah, you have to actually counsel the patient as well. So please read the task first, remember the task, and always make sure that you're not missing out the task. And the last 1 minute or so might be a good point of thinking very cognitively about if you're not missing anything. um, there would be some scenarios in which you've got absolutely no idea, but there won't be majority. There might be one scenario or a max two scenarios in which you're completely um, out out cold, that where am I going with this one. But if you're struggling, the chances are rest of the people are struggling, and the examiner may not be looking for a diagnosis or any silver bullet. He might be just falling in your communication, making sure that you're going through all the essential steps of developing a rapport, checking comfort, going through all the critical questions in terms of serious diagnosis and exclusion of the serious or life-threatening issue. So don't take that those very difficult scenarios are, you're not going to try at all. you need to give your 100% and make sure that you're still a very safe doctor, because that might be something that they're looking for in that scenario. And as I said, rapport is so important. And sometimes, we can be very pushed with time, and we might be pushing the patient in a such. And the words and sentences like that, I'm sorry to rush you, but I really need to know this. This is also a part of rapport, that you're trying to show that you have got little amount of time, and need to go through certain set of questions, but making an allowance for that, making an excuse for that. I'm sorry that I'm rushing you through, and I really appreciate your you know your compliance with me, and your help in this scenario, but can you just go through quickly with these questions as well? Thank you very much for this information. I'm going to ask you some more questions about your past medical history and social history, and some of these questions can be very personal, and I apologize in advance. Is it okay with you? So over and over again, just segmenting or sectioning your history seconds, and then going as you go along. Nervousness will destroy your pitch. Just remember that. And it's natural to be nervous. I think it's okay to be nervous in the first two station, but if you're getting more and more nervous, I always say go slow. Especially in the first two station, make sure that you're not just like this. Just make sure that you're going slowly. Hello, my name is Rizwan, I'm here to take the history. Are you okay, comfortable? Let me offer you some analgesia. Let's start off. What's on your mind? Can you please tell me what's wrong with you today, or what has brought you to come seek a medical advice today? So keeping it slow will make sure everything is well settled. If you go and talk very fast, everything will be rattling in your brain. You don't want to do that. Okay, that's the history all done for me. And any questions at this stage? I don't think that we've got any question. I'll jump into the communication side of things. Now, look, I mean, verbal communication and non-verbal communication, we all know about that. Non-verbal communication is one of those things which are very artificial in an exam scenario, like your facial expression, especially if you're doing an online version of that. Your facial expression might be just lost with the on a Zoom. Your tone of voice might be something which not may not get transferred across in an online format. So I'd say non-verbal communication right now for an online exam is your clarity, is your simple selection of simple words. Your eye contact is again compromised in an online format. So that's why I tend to like in-person exam. So lots of people are avoiding in-person exam, but I would say that it gives you an edge in all those non-verbal communication skills. So just make sure that in any scenarios, even if it's an online or not online, you greet and smile. Unless and until obviously it's a Breaking Bad news scenario, then you don't have to smile. In fact, smiling may go and count against you. Have an upright posture. Don't have a relaxed posture like lying down or completely relaxed like this. Make sure that you've got a reasonable posture and your visibility is good. And AMC will go through all those checks with you. Eye contact is important, especially if you're doing an in-person testing, and empathy, putting yourself in patient's shoes, that if I would have suffered from the same symptoms, how would I feel, and how would I like to be treated myself? That's one of the most golden things about medicine. All right. And yes, this is important. Pauses. Give I like we're trying to fit in quite a lot of information in 8 minutes or 7.5 minutes, and giving 3 to 4 seconds at the end of the history taking, and then transitioning into saying that, look, okay, I've taken the history. Thank you for that. I would like to talk about some of the tests that I'm going to do. And between that transition, just taking a pause and then developing a rapport kind of sentence. Thank you for all that information. Let's go through some of the other questions. Does it make sense, Dr. Ramsha? Anything to add on?
Yes, it makes sense, doctor.
All right, perfect. Um, Verbal communication skills are all about having the clarity and content speech. Uh, you very, speaking in the words. Sometimes you can say that you can count, but that would be way too slow. But at least slow enough for the person to be able to understand. It's not about the accent. Please don't get me wrong. Your accent does not count against you. I've seen plenty of people who've passed AMC and who are actually working with me in the hospital settings, in ICU settings. So it's not about your accent. It's about how clear and how how focused you are towards your clinical scenario. Um, okay. All right. And we've covered most of these things: introduction, tasks, summary, and question and answer. So I won't go through that. And as I said, using pauses. Now, some of the specific things about questions when you're opening up with the statement, instead of why you're here and what brings you here, use the word can I help you, or how can I help you, Mr. Culshaw? I believe that you're here with some, chest pain, or as I said, shortness breath. I believe that you're here to get my, advice on your abdominal pain. How can I help you further in that regard? So using the correct terminology. Repo can also be, emphasized by the points of mnemonic far, like, is there any family or friends you'd like to be here? Is there something I can offer you in terms of analgesia? And reassuring that, look, I can reassure you that you will be taken care of. We will try to get to the bottom of it, and we'll try arrange an adequate follow-up, so you're well looked after. So remember this mnemonic far, which can address quite a few concerns when it comes to developing a rapport, empathizing with the patient, and so forth. All right. Um, Breaking it in sections. So there's quite a lot of components of the history in terms of presenting complaints, HOPI, systems review, past medical history. And I'd like to break it in. So you go through the presenting complaint, HOPI, and systems review. And then after that, you take a 3-4 second pause, and you can say that, look, I'm now going to ask you some questions about your previous medical history, including some drugs that you take regularly, and go through some allergies. Thank you very much for that. Now I'm going to ask you some personal questions. Where do you live? And if you smoke, and about your drinking habits. And some of these questions I can understand could be quite personal. So if I have your permission, would you be okay with that? So just having that approach of partitioning that, it would keep it simple. All right, and keep the diagnosis simple. Okay. One of the things which I have recently seen many of the IMGs, and I was in the same ballpark figure, and I see the same mistakes is still occurring, is we tend to be, using less words when you're giving a diagnosis. Um, you need to sentence it rather than word it. Meaning that if the patient is coming with abdominal pain, with right upper quadrant pain, tenderness, and fever, and you're thinking acute cholecystitis, don't just say that I think you've got I think most likely diagnosis is acute cholecystitis. You can say that, look, Mr. Smith, I understand that you've come in with a few days history of some epigastric pain, which is going into your right upper side of the belly. We've also noticed you've got temperature. Based on my investigation with an ultrasound showing stones, I think the most likely diagnosis here could be the gallbladder stones or acute cholecystitis, which is an infection of the gallbladder. Does it make sense? So just picking up the positive finding and putting it there. Okay, so most likely diagnosis, then most serious diagnosis, which in this case of acute cholecystitis could be pancreatitis, because in this country, alcoholic pancreatitis and gallstone pancreatitis is the leading cause of pancreatitis. And obviously, any abdominal pain, the worst case scenario would be perforation, bowel cancer. So touch base on that, because that is something which I'd be concerned about if I'm coming there as a patient. If I've got a cancer, have got like perforation or anything like that. Finally, management. And this is the part which most of us do a very bad job. And I'm absolutely, a party to that, because I started out in the same way. Unless and until I did my own fellowship and my licensing exam, I saw an approach that management can be general, specific, disposition planning, and follow-up planning. And finally, some red flags of advice for the patients to come back. So general management is where the patient may have come in with abdominal pain, the patient may have come in with chest pain, the patient may have come in with anything, dehydration from diarrhea and vomiting. General management is there to stabilize the patient condition. It's not treating the underlying condition. If the patient has got an acute cholecystitis or gallbladder stone, they may need an RCP procedure, they may need an operation procedure, they may need an eye biopsy. That's a specific to that particular condition. So break it down. That general will get you comfortable. Specifically, we'll try to identify what's causing that, and we'll try get you linked up with the specialist services to have a better management to that. Disposition means whether the patient needs admission or can this patient be managed as an outpatient. So admission or discharge. It's as simple as that. And follow-up advice and red flags to come back. Red flags are something which you must do in every case. If the symptoms deteriorate, if you've got any concerns, if you feel that you are not happy with the way that you mentioned, I would encourage you to come back. All right. Finally, as I said, confidence is very important. Clarity of speech is important. Bridging every time with empathy. Thank youing the patient. Thank youing, is that even a word? I'm not sure. Really, thank youing is a word. And are you okay to answer questions? That's all part of the repo that should keep on continue. And recheck the tasks. There might be a piece of paper there. Make sure that you have got last minute that you can catch it through. Any questions at this stage?
Yeah, sorry, I have a question.
Go for it, Ramesh.
Regarding the explaining the diagnosis as well as management, in exam setting, are we explaining it to the patient or to the examiner, the diagnosis and the management?
So I think in an online format, you don't have an examiner in front of you. You may have a patient or an actor in front of you. So you would focus, you're still, you would still focus your commentary towards the patient.
So in case of the management explanation, do we have to tell the patient that I'll be, for example, just say it's a case of septic shock, for example, do we have to explain to the patient, I'll be inserting an IV cannula for you, giving some fluids? Are we allowed to use the jargons?
Look, I think this is something which is very specific. I don't think that you would be expected to communicate to the patient when you've got shock, because that is just too technical. There might be a scenario in which you're trying to explain an ECG or a septic shock management to a medical student. Yes, you can use that medical jargon. But most of the times, you might be talking to a relative of an elderly patient who's gone into like an aspiration pneumonia related septic shock. So I think it varies from case by case basis, but certainly in a very bad set of diagnosis of septic shock or peri-arrest, you would be communicating with the patient saying that you would be putting in a cannula and things like that. Having said that, if the scenario demands that you need to do bloods, then yes, you can say that, look, what we have got right now, say for instance, if we take an example, and we'll go through and do some examples as well, but if you've got a patient who has got like say gallstones, okay, so something like gallstone related acute cholecystitis, and you need to do bloods and blood cultures, you can say that, look, clinically I suspect that you might be suffering from a condition called acute cholecystitis, which means that infection of your gallbladder. And in order to confirm this diagnosis, I would have to put a little cannula in your arm, take some bloods and test it in the lab. And at the same time, we'll utilize that access to give you some antibiotics. Does it make sense? And then take it further.
Yeah, so just to clarify, right, just in case in the exam scenario, they mentioned explain the diagnosis and the management to the patient, then we will be explaining in layman term rather than using the exact jargon, correct?
Yes. So
But
if you are, sorry, go on, Ramesh.
Yeah, so but just say in the scenario, they say explain to the examiner your diagnosis and management, then the approach will be completely different. Will they specifically say what's the approach supposed to be?
Yeah, I think it would be written in your task. And if you're explaining to the examiner, then yes, the task would highlight that, and then you can use the medical terminology. And obviously, if it's explaining to the patient, I think it's always good to use a combination or a hybrid approach of having both technical terms, but then breaking it down to more layman terminology.
Sure. Sorry for a lot of questions.
No, that's okay. I like questions. At least it makes me think that there's somebody's there, not just, blank screens. Dr. Ramsha, would you like to add on to Ramesh's question if there's anything else in terms of that specific question with regards to technicalities or anything?
No, doctor, I think what you mentioned was appropriate.
Okay.
Enough.
So we'll start with the case one, and I may select a volunteer. This is one of the cases I think which has been recently come in one of the recent scenarios. I've polished it a little bit and I've added a picture from a case that I saw recently. So I think, when it comes to the AMC cases, they are a case which are commonly occurring in an emergency settings or in a GP settings or in a combination of both settings. So this is a case. Who would like to do that? Dr. Ramesh? can I please
Yeah.
request you to go for it, if that's okay?
Sure. I'm from a medical background, so I will try my best.
Go for it, please.
Sure. So we start now.
Yes, please, go for it.
All right. Hi. Good afternoon,
So no,
Mr.
just read the scenario first,
Yeah.
so
Oh,
everybody's on the
sure.
same page. Yeah,
All right. Sure.
you can read it aloud.
Should I read it out? All right, sure.
Yeah.
So Mrs. Reagan is 72-year-old lady who has presented to the hospital with 4 days of right-sided toothache and mandible swelling. In the last 2 days, she has noticed lump developed left side of his face,
Of her
slowly
face,
extending.
sorry.
Yeah,
Should have said.
slowly extending towards the neck. The lump is painful. The
Mhm.
vitals are heart rate 102, temperature is 38, blood pressure under 10/80, and the saturation is 99% under room air. The
Mhm.
task given is take history from Mrs. Reagan and what are the possible diagnoses and differential diagnoses. All right.
So immediately after reading this scenario, would have like an absolute brainstorm rather than brain freeze. What's happening? So you already know what's happening. The picture is in front of you. I think in examination there might be a picture, might not be a picture, but I've just reproduced a picture because it just accentuates the process a little bit more. So I'll give you some time to collect your thoughts, and we'll go and do this case quickly.
Yeah, sure. I think I'm good to go.
Okay, Dr. Ramesh, go ahead. I'm
Yeah.
Mrs. Reagan. I'm your patient.
All right. I'm starting now. Good afternoon, Mrs. Reagan. I'm Dr. Ramesh. I'm the doctor in charge for you today. Before I start, is it okay if I confirm your identity? Are you Mrs. Reagan?
Yes, doctor. I'm Mrs. Reagan. Yes.
All right. I understand, Danny. You're in a lot of pain today. So, is it okay if I ask you a few questions regarding your pain so I can help you further?
Yes, please, doctor. Go ahead.
All right. At this point, before we go further, is there anything that I can help you with? Any painkiller I can provide you, or is there anyone else you would like to join in the room?
Oh, thank you for asking, doctor. But one of the nurses has very kindly given me some endone, and I'm comfortable now.
All right, sure. I hope you'll feel better soon. We will try to get to the bottom of this. All right. All right.
Okay.
Mrs. Reagan, is it okay if you tell me more about the problem that brought you to this?
Yeah, doctor. So, what's happening is I've been getting a lot of toothache. I've been to my dentist a few times, and he said there might be some cavity building in my right or left side of the tooth. He did some cleaning up and some therapy, which helped a little bit. That was about a week ago. But in the last 4 days, the pain has come back, and now I've seen that it is causing some of the swelling. And I'm quite worried about this swelling because since yesterday this swelling's actually become quite firm, and it's very sore, and I've gone to the GP. He's put me on some very strong painkillers, and then there's been some pus coming out from the swelling, and it just seems to be enlarging. So I'm quite worried here right now.
All right. Apart from that, is there anything else that's bothering you?
I've also been getting fevers, doctor, and feeling hot and cold. My appetite is just reduced. Especially, I cannot chew because every time I try to chew, it just hurts me too much in my jaw. And my swallowing seems to be affected as well. Like, I mean, it hurts to swallow.
All right. That must be very difficult for you. Is it okay if I ask you further? I would like to summarize, everything started with a toothache, correct? 4 days ago. And then you visited your GP who prescribed you with antibiotics.
Yeah.
All right. And the antibiotic did not seem to help you, correct?
Oh, I mean, it did help me, but then again, I have noticed that this swelling has developed. So the tooth and
Sure.
the antibiotic and therapy did help me, but then this swelling started a few days later. It seems to be
Sure.
getting worse. I'm getting fevers now, which I was not getting initially, and I'm very worried about this because I've got a few things which makes me quite vulnerable to these infections.
Sure. Sure. Before we go further, is the swelling painful?
Yes, doctor, very painful. In
Alright.
fact, when I went to Dr. Nathan yesterday, he put me on some patches for the pain.
Sure. All right. So apart from the pain, you're having difficulty in swallowing as well as you're having fever, correct? Did you take anything
That's
for
right.
the fever?
I've been taking Panadol, but the fever comes back in again.
Sure. I would like to ask you further. Is it okay if I proceed?
Yes, please.
Is it? Do you have any vomiting or any diarrhea, any stomach discomfort?
No, doctor.
All right. Do you have any chest pain or difficulty in breathing?
No, doctor.
All right. Is there any issues with your waterworks so far?
Sorry, with my what?
Your urine? Is it okay?
Oh, waterworks. Okay. Yeah. No, my
Yeah.
urination is fine. Thank you.
Sure. So apart from the swelling over your neck, do you have any other swelling elsewhere?
No, doctor. This is the only swelling right
All
now.
right. Is it okay if I ask you further questions regarding your previous medical problems? Have you been admitted before, or do you have any other medical problems?
Yes, doctor. So I have got a condition called osteonecrosis of the jaw. It developed late last year. I've been following with this maxillofacial surgeon who's been keeping an eye on it, but it has never given me a problem like this. Obviously, it causes some mild swelling, it causes some pain. Of late, the pain has been a main issue. I've also got rheumatoid arthritis, and yeah, I suffer from asthma, but my asthma has been well controlled.
Sure. All right. May I confirm the osteonecrosis? Is it the same side? That's your right side of
That's
your jaw?
right. Yeah,
All right.
yeah,
Sure.
yeah.
All right. So understand that in view of your rheumatoid arthritis, you should be on a lot of medications. Am I right?
I am on a few medications. That's correct.
All right. Do you have the list of your medications currently, or do you remember the name?
Yes, I do remember. So I'm on prednisone 25 milligrams daily. I'm also on methotrexate 200 milligrams daily. And I also take Plaquenil, which is known as hydroxychloroquine. And that has been on for past few months. And recently, a couple of days ago, my GP has started me on morphine patches.
Sure. Is there any other reason medication change?
No, no.
All right. All right. Just to confirm, Mrs. Reagan, do you have any allergies to any medications?
I have no allergies.
All right. And your GP provided you with antibiotics, right? Did you complete the course, or were you not able to finish it?
No, I'm still on the antibiotics.
Sure. Sure. All right. I just would like to ask further regarding your background. May I know what do you work as?
I'm now retired, but I used to work as a receptionist.
Sure. And did you have any smoking history, or have you ever
No, I
consumed
never
alcohol?
smoked.
All
No,
right.
and
Is
I
there
drink
anyone in
socially
your
over weekends.
Sure. Is there anyone in your family suffering from any recurrent infection or any other medical problem?
No, no.
All right, sure. Once again, confused. All right. So I think, Mrs. Reagan, thank you so much for giving me all the information. Is there anything in particular you're concerned about regarding today?
Yes, doctor. Look, I mean, as I said, that I am on these very special medication for my rheumatoid arthritis, and my doctors
Yeah.
always advise me that if there's an infection, you need to go to the hospital immediately. I'm worried about that this infection is unlike any infection. It seems to be spreading.
Sure.
It is causing some of the problems with my swallowing, and I'm just worried that this is not usually like with my normal jaw condition, and if there's something really wrong which may need I don't know, operation or something like that.
Sure. All right. Thank you for telling me that. I'm having the same concerns as well, Mrs. Reagan. It's because you're on certain medication that can cause you increased risk of infection. At this point, I'm worried that you might be having an abscess or an infection over your skin of the neck. You are right. In view of your medications and underlying problem, I think it's best for us to refer you to the nearest hospital for further assessment by a
She's come to the hospital in the scenario. If you look,
Oh, sorry.
yeah, she's presented to the hospital, so she's already in the hospital.
We will refer you to the ENT surgeon to have a look at you, because you also need to check your throat to make sure it's okay and the infection has not spread there. At the same time, since you are having difficulty in swallowing, if we might need to start you on some fluids to make sure you are hydrated. We will take some blood test for you to make sure we know what kind of infections are you having. And we will give the rheumatology team a call to adjust some of your medications that might worsen the infection,
Mm-hmm.
right? Most
Mm-hmm.
likely you will need admission. And after the assessment by the ENT surgeon, you might need some procedure to remove the abscess,
Mm-hmm. Mm-hmm.
right? Is there
Okay.
anything you'd like to ask me so far?
No, what do you think is wrong with me, doctor?
Um, should, all right, I'm thinking you might be having something called Ludwig's angina,
Mm-hmm.
or it might be mandibular abscess secondary to your tooth infection that you had.
Mm-hmm. Mm-hmm.
Yeah.
Okay. All right. I'm not sure about what Ludwig's angina is. Can you explain to me?
All right, it's basically an infection of the skin that can become complicated with abscess formation. And the source of infection for you, most likely, it is from your toothache. It's a bacterial infection. So most patients will do well with antibiotics, but some of them might need procedures to remove the collection. I'm afraid that you might need the procedure, but that will be decided by the ENT surgeon.
Mm-hmm. All right. Okay. Thank you, doctor. Thank you.
All right, thank
So
you.
I think we're just about the time mark.
Oh, God.
It's 3 minutes and eight. Sorry, three. It's about 8 minutes right now. Good, good, well done.
Oh.
Look, I think this is a perfect
Alright.
example on how a good communication skill person like you could fall an easy trap to some of the cases and its intricacies.
Yeah.
And look, I think if you look at the task, the task is history, which you've taken, and I think the history part was done very good. But the next task is what are the possible diagnoses and differential diagnosis. It was not really about the management side of things that
Management.
you were,
All right.
and you were in your stream of thoughts, and obviously it's quite natural to fall trap to that. We'll do this, we'll do that, and this is, and that's why when you said that, what are you, what is there any questions that what is wrong with me, what do you think is wrong with me, and then you said that it's got like big angina. And the other thing is that, look, it also shows in that we have not got any understanding about how the local system work. You said that we referred you to ENT surgeon, and she's telling you that I'm known to a maxillofacial surgeon, and in most hospital that's plastics surgery or maxillofacial surgery is a completely different department. So in Australia, most of these problems are looked after by maxillofacial and plastic surgeons. So that's the other thing which I will hold you to it. The other thing, Ludwig's angina is not a skin infection. A skin infection is cellulitis, skin and subcutaneous tissue. Ludwig's angina is the infection or the abscess of the floor of the mouth in the mucosal surface. So that is different to what you were trying to tell me, or this is different. So let's just go through that. And there's one thing in terms of red flag. She's already telling you that her swallowing is affected. The other red flag would be to check about the breathing, because aerodigestive compromise would mean that, look, she is someone who could decompensate, deteriorate, and you may need to get an immediate CT scan to make sure that there's no compression onto the trachea, there's no compression of the vital sort of breathing system and other things like that. All right. Okay. So let's just take it
Thank you.
systematically. Yeah, no, that's okay.
Yeah.
So look, I mean, this is a immunocompromised patient. Okay. So the history side of things was good. You were quite good in terms of taking the history, the segments of the history in terms of past medical history, medication history, social history. That was perfect. You confirm the allergies, which is very important because you're going to give me antibiotics, and that's important. Now, the other thing, which everything the patient is telling you has got something for you to work on when you're making your diagnosis. So remember the diagnosis step, as I was telling you, Dr. Ramesh, that you tell the patient what's wrong with them most likely. So you're right that this is an infection involving the mandible on a background of a patient who has got osteonecrosis. Now, what is osteonecrosis? Osteonecrosis is like avascular necrosis. Okay, avascular necrosis, we may have heard about avascular necrosis of the hip, avascular necrosis of the jaw, avascular necrosis of number of different conditions of the bone, which could be a complication of her, rheumatoid medication like methotrexate or Plaquenil that she suffered, like avascular necrosis. You remember that previously in the day, the patients who, or still to the day, the patient who suffer avascular necrosis of the hip bones are the patient who are on steroids. That's one of the recognized complication. So that is what's happening here. So she is been treated with prednisone for a long time, and that has caused complications in terms of recurrent infection. And that one infection previously, which might have been partially or inadequately treated, may have left her with avascular necrosis of the jawbone, for which she's already known to a maxillofacial surgeon. So when you're giving the diagnosis, you can say that based on the immune condition that you've got, which is rheumatoid arthritis, and you being on the medication which suppress your immune system, But one of my concerns right now is that you've got a pus collection, which is we also called an abscess involving your jaw area or mandible area. And I think this is one of the areas which is very close to the breathing structure and swallowing structures. We need to get some further investigation to see if there's any compromise from that. Does it make sense, Mrs. Reagan? And she'll say, yeah, it makes sense. Obviously, I've got rheumatoid arthritis. I'm on prednisone, methotrexate, plaquenil, and yes, he's on the right page. The other differential could be a dental abscess because it did start with a toothache, and it could be a partially treated dental abscess. And I've seen dental abscess having skin extension. And look, in this kind of age group, it's always good to think about some sort of malignancy, especially if the patients had recurrent infections, have got a chronic condition, have got methotrexate and other chronic condition, then it could be a manifestation of an underlying malignancies. And malignancies can acutely present with, infection, clotting disorders, bleeding issues. So think about that. Does it make sense or does it not make sense?
Yeah, sure.
So you can see that, look, this scenario, even though it looks seemingly simple, but could be very challenging if you're not really addressing the right things. And she is febrile, although she's hemodynamically stable. Any questions from the rest of the people here?
I have one question.
Yes, Dr. Damitong.
If she go further than the possible diagnosis and differential diagnosis, and she go to the management, that she is right about the diagnosis and differential diagnosis, that means she completed the task, would
So
be penalized of saying too much?
look, I mean, if you put time, and if you think that you've covered all the tasks adequately, then you can briefly talk about the management. That, look, this is one of the things which would require you to be admitted into the hospital under maxillofacial surgeons. We would initially start you on a treatment with antibiotics. We'll take some cultures and get the CT scan done. So very general introduction of management. I don't think that you'd be penalized, but it would not give you any additional marks because this is something which is not really utilized. It's just to fill in the time. I think focus more on the diagnosis and differential diagnosis. That would be my recommendation because you're not going to gain any extra months if you're managing the case.
Okay, thank you.
All
I
right.
understand.
Any other questions?
The reason, just a quick one. For example, in this case, this patient is obviously having a problem in the mouth, right? So during my systematic review, is it okay if I ask regarding the urinary tract infection symptoms just for completion's sake, or do you think that's not a good idea?
Very good question. I think that's a brilliant question. Look, this is an elderly patient, okay, and you always have to screen for an infective source. So even though an obvious source of infection could be this mandible, but it's good to do the screening tool in terms of UTI, recurrent UTIs, or in terms of screening tool for chest infection or any other infection, because she may have an abscess here, but she may have pyelonephritis, albeit it's very unlikely, and that too in an exam settings. But it just shows you being very thorough doctor, that you're just screening for any other infections. And if I was to see this patient on a floor and I'm referring to the maxillofacial surgeon, trust me, they would want to know that if other source of infection like chest x-ray and urine and the other source is connected. And look, this is all built up on your history, and you need to make sure your history is reflected of very, very robust approach.
All right, thank you.
Okay. Any other questions, guys? Move on to the next case. All right. Okay. Who'd like to do this case? Very common scenarios, get asked a lot of time. I think it came on recently in March as well. I've modified that to how it should be asked. And yeah. So whoever does this scenario is doing themselves a favor. Anybody? We've got about 23 participants here. Anybody would like to have a crack at this one? Come on, it will be fun. Anyone would like to go through?
I can take it.
Yeah, go for it. What's your name? Sorry.
My name is JP.
Okay, Dr. JP, please go ahead.
I can't see the case. I don't know what I did here.
You can't see the case?
I can't see the case.
Sorry.
I don't know where it touched. Maybe.
Can you see the case one? Can anybody else see the case? Dr. Ramsha, can you see
Yes,
the
I can
case?
see the case very
Yeah.
clearly.
I can see
Yes,
as well.
I also see it. And the second case is also okay.
Yep, yep.
Oh, unfortunately, I can't. That's okay. Somebody else can do it.
Okay, all right. Anybody else would like to have a crack at this case quickly?
Okay, I want to try this one.
Okay, go for it. What's your name? Sorry, I haven't.
Dr. Dong Tong.
Okay, Tom, please go ahead.
Okay. To need read.
Yep, go for it, please. You can read it aloud if you like.
Okay, thank you. Harry, 33 years old, keen runner who has presented to the hospital with sudden dyspnea and chest pain. His vital is heart rate 102, temperature is 36.6, BP 110/80, and oxygen saturation 92 room air. My task is to explain chest X-ray findings to the medical students.
That's me.
Yeah, and explain the positive and relevant negative physical exam finding for each case with medical student.
Yeah, to the
Okay.
medical student. Sorry, yeah.
Okay, that's in
So
view.
just think about it for a few seconds, like give yourself another 30 minutes, 30 seconds or a minute, and then we'll start.
Okay, I will try.
Thank you, Dr. Romcom. Go ahead, please.
Okay. Good morning. May I know your name?
Yeah, my name is Rizwan. I'm one of the final year medical students, doctor.
So you are fifth year medical student, are you?
Yes.
Okay. So what can I help you today? It looks like
Yes.
you're going to ask me something about the chest X-ray for
Yeah.
the blind Harry.
So this is a patient who's just come to the department, the emergency department. He's a runner and he was running into this marathon, and he's come with with chest pain, and he's looks like a little bit short of breath. Someone's requested an X-ray of the chest, and it looks like there's something going on. I think I've seen these kind of X-ray before, and they're called pneumothorax. But I'd just like to get a better idea as to what are we looking for, what are the main things that I should look for, and and
Thanks.
how to diagnose these conditions in future. Is there a
So,
method of interpreting these X-rays?
okay. So first of all, I'm very happy that you asked me, and I will explain to you. And during the explanation, if you have some questions, you just ask me, and I will give you more clarification. And the scope of explaining today is about the general reading of the plain chest X-ray, and I think that's all. And yeah, I'm going to start by looking at when you have a chest X-ray like this in front of you. Make sure that you read the right one. This means you're looking for like the identification of this chest X-ray first, whether it's on chest X-ray or in the screen of the computer.
Okay.
Make sure it is the right one for Harry.
Yep, sure.
And second, you're looking out like first. So you're looking for the bone first. In this case, you will see that the bone, especially humerus, clavicle, and ribs are good. And second, you get closer to the midline, you will see that there's a right track here. I will see that is the deviation of the trachea to the large side. And on the left side, there is, I would say there is a total collapse of the of the lungs stick to the hilus. So this is a very serious case because the lung is totally collapsed by something else, and the trachea is already deviated to the right side. So this is a very serious one. And second, you look for the compared to the right side, which is normal. It is have a normal lung marking and also the lung parenchyma. And looking next for the heart, the heart side is rather normal because it's compared to the wine of the chest is approximately half of the width of the chest. And next thing is looking for the diaphragm. The diaphragm on the right side is okay, and the diaphragm on the left side is slightly depressed, which may be normal in the people. Okay. So in this case, combine all of the things from the history of Harry and physical examination, especially the White House and oxygenation, which he has only 92 for room air. I think in this case is indicate that he has a tension pneumothorax, which is a life-threatening condition, which immediate decompression. Actually, tension pneumothorax should not need an X-ray. You can make a diagnosis by just taking the history, taking a physical examination, and you have to diagnose him right on the bay.
Okay.
And
so, doctor, it brings me to my next question. What would be the positive and relative physical examination findings if I was to see a patient with a pneumothorax?
Okay, sorry about that. That I missed my point. And the positive finding for the pneumothorax is you will not see the lung marking on the affected size.
No, I'm talking about the physical examination, not
the
the
physical
X-ray.
examination.
Yeah. So this is the task number 2. Explain the positive, relevant, negative physical examination findings of the case of medical student. Yeah.
Okay. So the physical examination, the positive one for the this case, you will not hear the breath sound of on the left side, and you just hear the right sound just on the right side. You will feel that the trachea is deviated to the right side, and you will, if you record his BB, you may he will have like a tachycardic, and maybe if it is severe enough, he will have a drop of BP. And furthermore, the patient will be dyspnea and tachypnea. He may also have diaphoretics and cyanosis if the displacement is severe enough to decompensate the vascular return from the general system. And yeah, you will see that he also has reduced oxygen saturation, which is just 92% on room air.
Okay, time's up, Dr. Tom Tank.
My first time, very bad.
Okay, no, that's okay. You did rather well, actually. And look, I mean, this is again one of the things that scenarios in themselves are not difficult, but it's the information that require you in a time, which tends to be a bit of an issue. So, look, I think plenty of good things there, yeah, and I think I'm just pushing you because of the time. We've gone through 8 minutes, and yes. So basically, your opening up introduction was good. That you've encouraged me as a final year medical student to ask questions later. Always check what level students if they are, and if they've had any previous teaching in chest X-ray interpretation. And also put on one more question: what is your expectation? And he's already told you an expectation that, look, I've seen this X-ray, I think there's something abnormal in there, I think it's an pneumothorax. Can you please tell me about what are the positive and negative signs to look out for, grade the severity of pneumothorax? So he's come up with his plan of learning, or learning outcomes, what is called. Now, good start in terms of identification and correct patient, correct investigations. Then have a system in terms of, like, I'll put up this X-ray in front, in which I've recorded there. Have a system, either go from center to the side, or go from the pathology and then talk about the rest of the bits and bobs. So you can say that, look, it's a chest X-ray, PA view or AP view. I'm not sure. It does not mention. Maybe it does. No, it does not mention. But it looks like a posterior anterior view to me. And it shows, one of the things which it shows is obviously a condition called pneumothorax. And let's just interpret that. Why am I saying it's a pneumothorax, and uh, what severity of pneumothorax? Is it a small pneumothorax, a moderate size one, or it's a large size one as an intention pneumothorax which needs immediate intervention? And you were quite right in saying they don't even need an X-ray; they need to be diagnosed clinically. So the system that I've got, like, you can start off with, always good to start off with the center. Like, you can look for tracheal deviation. If you start from the center, go to mediastinum, and then go onto the lung fields, then you would not miss out much. So you can comment on the tracheal deviation. The trachea is midline. Sometimes, because there is an abnormal air collecting on the left side, the trachea might be pushed onto the opposite side. And looks like in this case, it is getting pushed onto the left side. So that means there's a large collection on the left side. Also, if you look at the mediastinum, which in cases the heart seems to be a little bit shifted onto the left side. So then make a comment on that. Again, in the midline, mediastinum shifts to do the left side. Now come on to the pathogenic sites, that you can see that there's no lung marking. If you see the right side of the chest, you can see these vascular marking. But if you see the left side of the lung, there are no vascular markings, just air in there. So that is, again, one of the positive radiological findings. Um, you can also make a comment on if there's any subcutaneous emphysema. Now, normally that's in a context of a trauma or a rib fracture. And even if it's, sometimes the pneumothorax could be very small, and the indication of the pneumothorax on that side could be just a broken rib, or if not a broken rib, you can see some subcutaneous emphysema. So make a comment on that if you see that. Now, one of the other thing is collapsed lung, and you can see that collapsed lung in the X-ray here very distinctly. So this is the lung which is punctured or collapsed, and that's what's giving rise to all this air, or all this air here. So make a comment on that. This is all that collapsed lung. So this is in keeping with the findings of collapsed lung, large air collection onto the left side, which is pushing the trachea and mediastinum to the right side. It is most likely to be a tension pneumothorax on radiological. So there is a radiological tension and there's a clinical tension. If you look at the clinical scenario does not show that he's he's a early hypoxia, and he's still hemodynamically stable. So he's not decompensated. He's a bit tachycardic, but his blood pressure is still okay. So that means that you need to act now to prevent him going into the full-blown obstructive shock. So it's always good to describe the X-ray and interpret the X-ray, that these are the findings suggestive of an early tension pneumothorax which needs immediate decompression. Beautiful wording. I love it. Next, he was asking about the positive examination and negative examination findings. And you can say that, look, again, start off with the examination findings level of understanding. Like, have you had any opportunity of examination of patients with the chest conditions? Like, have you done a chest examination before? Have you in particular examined any pneumothorax patient before? Make sure that you take the consent, you clean your hands, and you approach the patient when they're comfortable. Always, whenever you're doing the physical examination findings in something like that, start off with the vitals. So mention that you need to recheck the vitals and make sure that the patients are hemodynamically stable. You start off with the inspection. An inspection could be from the neck, like distended neck veins. The patient might be pale or distressed, and only the one side of the chest might be moving, which in this case might be the right-sided chest because there's some air exchange happening in there, but the left side would be completely still. So these are the inspection findings. Make sure, obviously, before the inspection finding, your exposure is good, taking the shirt of the patient off. Um, Also palpation, like, I mean, go through all the steps which makes you think that your thoughts are organized. In terms of tracheal deviation, you can say that you can put your middle finger in that sternal suprasternal notch and just palpate for the trachea and check if it's shifted to one side or the other, which might be an indication. As you said, it's a clinical diagnosis of tension pneumothorax, so that would be a clinical indication of left-sided tension pneumothorax. You can check for the lung expansion on the affected side, which in this case on the left side would be reduced. And when you're percussing, there will be hyperresonant or hypertympanic sound on the affected side because there's just air in there. There's nothing else. Absent breath sounds on auscultation. So these are like few things which you must say. And at the end of describing all the positive findings, you go through some of the, other clinical situation. Make sure that to complete your examination, you're also doing a cardiovascular examination, and you get an X-ray done. So it's good to just complete the statement in a clinical and put that into a clinical context. Does it make sense, Dr. Domtang?
Yes, that's mean the second question is like another way to ask you, how can you do the physical examination?
Yeah.
I got it wrong. And
Yeah.
I just think it's just only what is the positive and what is the negative finding. And then just focus about the positive and negative ones.
Yeah.
So thank you for reminding me that it should not be like that.
No, not a problem. Not a problem at all. So I think that unless and until anybody else has got to say anything about that case, has anybody got any other points in this case? I think we're
I
fine.
have a question, sorry.
Yeah.
For example, explaining the positive and negative findings, right? So this kind of patients, I mean, this is about pneumothorax, but then when we come to lung examination, normally we'll talk about clubbing or nicotine stain, etc. Do we have to bring it up as a relevant negative?
No. So basically, this, if you read the scenario, it says explain the positive and relevant negative findings of this case with medical student. So you don't have to go to the respiratory because that would just take forever. Clubbing and cyanosis. I think the cyanosis would still pretty much be a part of this examination findings because you need to comment on that. That if there's any evidence of central cyanosis because the hypoxia is there. But don't go in as far as clubbing or anything like that. And sometimes the patient who come in with the patient who come with the pneumothorax could be the one with malignancies. So that is something that you need to keep in the back of your mind. But the scenario is very well laid out. He's a keen runner who was actually running at that time when he developed a tension pneumothorax. So just focus on the case. That'll narrow down the differentials and your discussion as well. All right. Okay. I might just jump into the last case before I give Dr. Ramsha a chance. And it's a very, very small case, which comes on quite a few times. My personal favorite case because it just lends itself to so much. Who would like to have a crack at this one? Anyone? I think Dr. Domtang and Dr. Ramesh seems to be the only two people in the whole class. And the next one is all silent.
I can take it. I can take it. I can see it now.
Okay, thank you. Go for it, Dr. JP.
Okay, so Mr. Raphael King is a 78 years old retired accountant who presents with weakness of his left arm and leg since yesterday. Initially, he disregarded this symptom and they were mild, but today morning, the weakness in the left arm and leg is worsening, causing difficult immobilization. His vitals, the heart rate is 82 per minute, the temperature is 36.6, blood pressure 110/80, saturation is 98%, room air, BSL is 6.7 mmol. Your task is to take history from Mr. Keane. What is your diagnosis and what are the differentials?
Yep. So I'll give you a minute to organize your thought. Not a minute, actually, just a little bit.
Okay. Okay, I'm ready.
You ready? Okay. So you're
Yes.
taking history from me. I'm Mr. Keane. Go for it.
Hi, Mr. Keane. My name is Jean-Pierre. I'm your doctor today. How can I help you today?
Oh, doctor, I'm quite concerned. Yesterday, I felt just a bit unwell. I wasn't really sure as to what's wrong with me, but what had happened is that I started to feel a little bit of weakness in my left arm, and then it sort of progressed into my leg. It was towards the end of the day and it was very mild, so I just didn't think of it as much. But this morning, I've noticed that weakness is actually quite significant. I cannot move my arm properly. It feels very heavy. And also my leg, I just seems to be not being able to put any weight on it. And look, I'm very worried what it could be, because I'm not able to walk, and it's something which has never happened to me before. And I'm 78, and I'm a bit worried about what could it be. Yeah.
I'm so sorry I've been through this. Yeah, it's kind of a bit concerning for a stroke. So I will be asking a couple of questions just to make sure we get the right diagnosis. Okay, are you comfortable now? Are you comfortable? Do you have any pain?
Yeah, look, I mean, I've got no pain, no, but I'm just a bit worried about what might be causing this weakness on my left arm and leg. Yeah.
Yeah. Just before, because I'm concerned about stroke, I will give you some aspirin, okay? And I will make a stroke call. And while I will be taking history, the stroke team will come to see you, okay? But I will ask you a couple of questions. So you have weakness of the left arm and leg, but do you have also numbness?
No, just the weakness.
Just the weakness. Did you notice any change in your speech?
No, my speech has been okay.
Okay. Apart from weakness, do you have also some miscoordination with your arms?
No, doctor. I mean, obviously, I'm not able to use my left hand and leg, but as opposed to my right hand, it seems to be okay.
Okay. And have you noticed any change on your face, like a facial droop?
I mean, I've looked myself in the mirror because, as you said, stroke. I looked it up, and it doesn't seem to be that I've got any drooping or anything like that.
Okay, no eye droop, no facial droop.
No, doctor.
Any change in your swallowing?
My swallowing seems to be okay.
Okay, and also, I would like to know, just about your background. Do you suffer from high blood pressure, high cholesterol, or diabetes?
I don't have high. I do have high blood pressure, but I don't have any diabetes.
What about high cholesterol?
No, I don't have high cholesterol.
No high cholesterol. Any kidney condition?
Any, sorry, what?
Kidney condition.
Kidney
like
conditions?
Chronic?
No,
not at all.
No.
Okay, do you smoke or drink alcohol?
I don't drink or smoke. I used to smoke, but I've given up smoking about, I think about last year.
Okay, how much were you smoking?
I am used to smoke like a packet of cigarette a day.
And how long did you smoke?
Oh, ever since I was 16, doctor. So yeah.
Ever since you're 16. Okay. Do you have any history of stroke in the family?
A stroke in the family? No, doctor, no.
Okay. Do you have any history of cancer in the family?
No, doctor.
Okay. Apart from the changes in your muscle power, did you notice any chest pain, any shortness of breath?
No, doctor.
Not at all. Any blurred vision?
No, doctor.
Okay. Any headache?
No, doctor. I did have a little bit of headache. Now that you've mentioned, I'm thinking about it. I may have had a slight headache. Actually, yeah, you're right.
Okay. A slight headache. Is that an unusual headache?
It's just like, I've got a headache, but not 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 too bad. But it's
Not too
it's
bad.
a little bit unusual that I've got a headache.
Okay. Is it solved now?
No, it's still there. So yeah.
Okay. I'll give you some painkillers. Do you have any allergy to medication?
No, doctor.
Not at all. Okay, I'll give you some Panadol. And do you have any neck stiffness? Not at all?
No, doctor, no.
No, not at all. Okay. And any tummy pain, any change in your bowel or
No,
urine?
doctor.
No, not at all. Okay. Do you take any regular medication?
Yeah, I do take Epixiban, 5
Apixaban.
milligrams twice daily.
What do you take Apixaban for?
I've had factor 5 Leiden deficiency, and I've had DVTs and PEs in the past.
Okay. How long have you been on Apixaban?
I've been on Epixiban for about 5 years now.
Okay. Oh, so you suffer from factor V Leiden?
Yes.
And you had multiple DVTs in the past, right?
Yes.
Okay. Have you seen a hematologist?
Yeah, I do follow up with the hematologist and Dr. Jeremy Squire. And yeah, he keeps an eye on, my condition, but I haven't seen him for about a year now. Everything seems to be going okay.
I see.
I also take amlodipine for high blood pressure.
Oh, you suffer from high blood pressure. Okay.
Yeah.
Amlodipine. Okay. So, okay. When you have this weakness, did you fall at all? Did you have any fall?
I did not have any fall, doctor. No.
Any change in your mentation or any loss of consciousness? Not at all. Okay, cool. So yeah, okay. So I would like to just talk to you about what are the main causes of your problems. So though you don't have many vascular risk factors, you have just hypertension. Also, you have this history of V Leiden and multiple DVTs in the past. That can be ground to have a stroke. A stroke is when you have some occlusion of your arteries in the brain and there's poor perfusion. And the area that's not perfused may have poor oxygenation because blood is not reaching there. And when that area is not well perfused and fed in oxygen, you have those symptoms because the one side of the brain, which will be the opposite. If you have left-sided weakness, it means the lesion is on the right side. So it may be a stroke. That's most likely causes, but it may be also because you are on apixaban, you may have a spontaneous bleed from nowhere. So that will be an intracranial bleed. And that's something we have to rule out. So we have to do a CT scan of the brain. It will be a non-contrast, so we don't give you a dye, but also we do something called perfusion scan. Okay, just to look, to see what if there are areas of poor perfusion.
Okay, what else could it be, doctor?
The other issues that may cause one-sided weakness.
I'm very worried about it because I've never experienced this kind of symptoms before. Like, and they're getting worse.
Yeah, for the moment, that's what I'm thinking about. But
10 seconds left, Dr. JP.
Yes. So in summary, you have these symptoms of weaknesses and it's pointing to stroke. And the only thing I didn't collect is the time when to happen, because it's critical for the intervention.
All right. Okay. We'll call it a day. Thank you. Thank you. All right. We'll stop here. Good. Excellent. Look, I think you covered most of the meat on the bones, as I say. It was good that you put out a stroke call. I would not rush in and do aspirin, because in hospital, you need to make sure that the bleeding is excluded and the patient is on apixaban. And you won't want to give aspirin in a patient who's had a bleed or
You're
suspected bleed
right.
in the brain.
Yeah.
So
Sorry.
just be careful there. It might be a critical
বেশি
error.
মনে লাগে নি তো 1-2 বার জাস্ট মুছছি
So just be careful there. All right. So yes, you're right. This is a 78-year-old retired accountant who's got weakness on the left side of the arm and leg. And one of the differentials could be a bleed. Well, it could be a stroke. It could be hemorrhagic stroke, or it could be ischemic stroke. They're both the possibilities. And I think apixaban has been put deliberately in there because they want you to think about intracranial hemorrhage. And hence, I think avoid giving aspirin in the first instant, which you reflexly would do for someone who's had ischemic stroke. But that's why in the real practice, we don't tend to give aspirin unless and until we've excluded a bleed. I think the devil is in the detail. Here, the history had a patient on apixaban, risk factors of hypertension and being a smoker, plus being on amlodipine. This needs to be established early on. So when you're taking the history, remember we were talking about the screening questions for ischemic heart disease, for stroke, for venous thrombotic issues. So make sure that it is a part of almost your HOPI, or history of present illness, in terms of risk factor for stroke. Have you got high? And I think you did go through quite a lot of them. You did ask me about high cholesterol. You did ask me high blood pressure, but go through some, like if you've had any previous TIA or stroke. You did ask me about the family history of stroke and things like that. So that was all good. Your screening test for speech, vision, and paresthesia were good. The other differential would be any sort of neck pain, which you did ask me if you got any neck stiffness, because it could be a sign of radiculopathy, right? If I've got cervical disc prolapse, it can cause like weakness of the arm and weakness of the leg if it's higher up in the cervical or thoracic spine. I don't know. Also, stroke mimics, be careful. Diabetes, you did check for. The BSL was 6.7 I've given you. So the BSL is normal. It's unlikely to be contributing to this focal deficit. Now, moving on to formulating our diagnosis, I like your style. And you said that, look, given the fact that your history and physical examination finding, I'm more worried about a stroke. And it could be a bleeding. So we'll do a non-contrast CT scan to make sure that it's not a bleeding. And then we'll do a contrast CT scan to find out if it is a stroke and it's, the brain is not perfusing the area. I think your description was quite excellent there. The time is of the essence here. Just make sure that you leave enough time at the end to summarize your finding. In terms of the differential, I'd say the stroke, either of hemorrhagic type or ischemic type. The other thing would be a mass lesion, which could be a primary brain malignancy or a secondary malignancy. The other thing could be non-compliance with the apixaban. So it could be thrombosis, and sometimes could be thrombosis from superior sagittal sinus thrombosis or anything else. So just make sure that you cover all bases on the history and the available information to you. Does it make sense, Dr. JP? Is there anything that you'd like to add on? Or somebody else like to add on?
Look, I think the feedback is really constructive, and I appreciate that.
All right. Okay. Thank you very much. Thank
I
you.
have a question.
Yeah, go for it, Dr.
In
Ramesh.
exam setting, right? So in this scenario, it's the question is what's the diagnosis and differential diagnosis. So in an exam setting, is it okay if I tell the patient, okay, most likely you're having stroke, and then we will proceed with further investigation and we will refer to the relevant department rather than specifying exactly what investigation we will do? Is that acceptable?
Look, the acceptable part of this scenario in particular is to give the patient the main diagnosis. As I said, the main or the most likely diagnosis, and two more most serious and less serious or less likely diagnosis. So the most likely diagnosis in this patient is a stroke. The most serious diagnosis in this patient, which could still be likely, could be bleeding or intracranial hemorrhage because he's on apixaban. And in terms of a brain lesion, which could be a primary brain malignancy or secondary brain malignancy, in terms of your question is whether you can mention we can do that or establish that by doing some further test. That's fine. But as I said again, you're not going to get any extra marks for that. You're getting marks for your primary diagnosis and differential diagnosis. So make sure your differential diagnosis list is, long. It has
All
got
right.
stroke, ICH, or ischemic stroke. It has got mass lesions, primary versus secondary. It's got cerebral venous thrombosis. It covers, other variances like subarachnoid hemorrhage, intracerebral hemorrhage, interventricular hemorrhage, all of that kind of thing, or cervical radiculopathy, even like if he's got a disc prolapse, which might be causing all these weakness. So make sure that your diagnosis and differentials are long enough, because that's where you're scoring marks. If you go and venture into the diagnostic modalities, rule in or rule out, although it's not a part of of your mark scoring, you won't be giving marks for that. So you would be mentioning it for the sake of mentioning, but you won't get any extra marks for that. Does it make sense?
Is it? Yeah. One more question. Is it okay though in exam setting, if you tell things like you might be having subarachnoid hemorrhage, which seems like medical jargon, is that
Yeah.
acceptable?
Yeah, no, I don't think so. When you're talking to the patient, you need to keep it
Mm-hmm.
simple. So I would
All
use
right.
the word, even the word of stroke is not very common, but you can
Mm-hmm.
say that, look, you're having what appears to be stroke in which, a part of your brain is not getting enough oxygen or blood supply, which is because of a clot formation.
So every differential diagnosis that I provide, I will need to have some form of explanation given to the patient.
That's right, especially when you're talking to the patient.
Yeah, sure. All right. Thank you.
Yeah. All right, Dr. Ramsha, would you like to add on? Sorry, I'm just.
No, doctor, I think the doctor gave a good case presentation,
Mhm.
and he had a lot of DDs, but he
Mhm.
missed some.
Mhm.
But I think overall his history taking was really nice.
Good. No, I agree. He did
Yeah,
cover quite a bit. Look, before I get Dr. Ramsha to discuss, she's got, I think, a case or two. I'll just talk about our cases. Sorry, courses, not cases, courses. So we tend to do two courses, core AMC course and comprehensive AMC course. They're both for morning and evening sessions. The website has got all the details. The website is emergencyfocus.net, and you can jump onto that. And in terms of core AMC course, it's got 100 hours of CPD, 8 weeks, goes on with one-on-one role play sessions, and it's gives you 3-month online access to the portal. So our portal is I'll show you the portal, what our portal is. It's like an online software which you have got all these scenarios and lots more, which are organized in chapter wise and topic wise, like pediatrics, ONG, medicine, surgery, and all that. Plus, on top of that, you got videos related to each of the scenarios, and plus you've got like notes, so detailed guidelines and notes all built into the portal. uh, Now you get access to the portal for the duration of the course, in fact a little bit longer to the course. One of the feedback from the current participants that we were not adding the videos from their session, but this time I'll make sure that I'll keep on adding the videos. So it has already, as you registered right now, you'll have almost access to 180 hours of recording immediately, but I'll keep on adding more videos from the current session for the new participants based on the feedback. So um, there we go. That's how the portal looks like. It's on the website that you go through in terms of accessing the portal. It's emergencyfocus.net, and you can, there's a link in there, it'll link you through that. And it's a complete reference source. It's got, as I said, videos and notes. It also checks up on your progress bar because it is linked to your individual identity. So it'll keep track of your progress bar, and your CPT certificate will come as the progress bar reaches 100%. And I'll be adding more new videos and more live sessions onto that. This is how the inside of the portal looks like. As I said, this is the progress bar, and then you've got all the sections organized into introduction, pediatrics, and other sections. This is the scenario which is going on, in which the video is running, and then this is the some of the notes that you can go through, and things like that. So I can do a live demo, but I won't keep Dr. Ramsha on because I think she's got some cases. So I'll stop sharing my screen, and I'll give Dr. Ramsha the chance to share her screen. Dr. Ramsha, can you share your screen?
Yeah, sure. Can you see?
Can't see the screen right now. Hang on. Try now, please. Sorry, my
Okay.
fault.
Okay. Can you see now?
I can't see still. I think I've stopped sharing my screen. My sharing is gone, right?
Yeah.
Okay. Just give me a second. What I'll do is I'll make you a host. So in that way, you've got more privileges than me. So try now.
I am trying.
No, do you see the share screen thing?
Yeah.
So if you press the share screen,
I am doing that, but it's some problem is coming. I think my MacBook Air is not allowing.
it's not allowing you to share the screen.
Yeah.
All
Nico.
right.
I'll just.
Would you like to? Because the thing is that I should have asked to. I'll
Just
let you set up. Yeah.
yeah, you can
While
continue your
yeah.
live demo, and I'm just
Okay.
trying to do this. And just give me
Anybody?
5 minutes. Yeah.
That's okay. That's all right. So anybody else has got any further questions for me? So somebody's asked me a question. Any shorter course, 7 day or 4 week? We've got. We're basically working on a crash course, but right now it's linked to already our courses which are running. So our next batch of courses are starting from April, and hopefully, we will try launch, a boot camp. There's currently a 5 day boot camp which is on offer, but we haven't got like 7 days yet. But I'm working on it. So hopefully next time around we'll have a better structure, because there's been a lot of requests from that point of view. Any other questions about the cases that we've gone through and done?
Rizwan, I have two questions. One
Go
is
for it,
regarding
please.
the boot camp.
Mhm.
The boot camp, do I get access to the portal as well?
So if you are registered as a course participant, you will get an access to the portal. Yes.
So for the 5 days boot camp that's starting tomorrow, how
Oh,
long do I
boot
have
camp.
access
Sorry.
to the portal?
Oh, boot
Yeah.
camp, for the boot camp. Not for the boot camp, because boot camp's got more different cases. In terms of the cases that we are concentrating on boot camp are more high yield cases, which have been repeatedly asked in examination. What we've done is we refined those cases, try make it more legitimate and more doable, as opposed to the recalls which have got part information. So they won't be in there, but you will have an access to the videos from the boot camp.
All right, sure. And I would just like to ask, how often, because I'm actually a bit worried about my pediatrics and psychiatry part. In among the 16 station, what's the ratio like? Do we always get pediatrics, or is it very unpredictable?
No, you do get pediatrics. I'm not sure. Dr. Ramsha might be able to shed some light onto it. Like, how many pediatric cases do we get? But I think you get about 10 to 20% pediatrics consistently.
Yeah, we get about 2 to 3 cases.
All right. Okay. Anything else that you'd like to talk about or discuss? All good? I think we're all good. Dr. Ramsha, how are we doing from the
Yes, Dr.
slides?
Rizwan, just give me 2 more minutes. I am.
2 more minutes. Okay.
Yeah.
That's okay. So look, I mean, I think from the point of view of our courses, the next batch starts uh, Monday. So if you have got any reasons for join morning sessions or evening sessions, please do join us. We've got a few spots vacant, and we can take you on board. Be pleasure to work with you guys. What I'm trying to do is get more collaborative link with all the participants, so we can all meet more frequently and do these open sessions in which you can bring the cases to the session, and we can solve those cases together. So that would be something which I want to try and new, and we can just try solve cases which are bothering you. We've also got access to our, you get put into a WhatsApp group, and I've seen many participants who join the courses, and they just make subgroups of these courses, and they tend to remain on these subgroups and practice with each other, because this exam is all about practice, and practice alone. And if somebody is telling you otherwise, that you can just watch videos and read about it, they're not really being truthful to you. I think practice, there's no replacement of a practice. And yeah. All right.
Do you give a receipt for the course fee?
Yeah,
Like
absolutely.
a
You get a proper invoice for the course fee immediately
is
when
that
you
something
register.
we can claim for refund? Like
Absolutely.
tax?
Yep. Yep.
Okay.
So our company is registered for tax purposes, and when you register for the course, you will get a receipt in the email immediately through the website, and you can use for your GST claims or from your tax refunds because it's a part of